Um, Before I get started, I want to tell you a little bit about my life journey because I think that it's important so that you understand my life philosophy. My life philosophy actually bleeds into my nursing practice, and it actually aligns with Dr. O'Rourke's theories. I was not planning to be a nurse either. My first 2 years of college, I was a pre-law major. And the reason why is because I felt like I wanted to make a difference by changing the laws to be more fair and equitable. I also was a teen parent. I had both my children before I was 19 and I was divorced. So raising two children when you're a teenager, and you don't know a whole lot about life, it's an adventure for all three of us. And I'm excited to say that my oldest child will be 15 next month. He looks older than I do. And my youngest child is 46, and they're both very successful, very good people. So in spite of the fact that I didn't know much about life myself, I was able to instill in them what I did know, and the rest we learned together. I ended up in nursing because I needed to figure out how to take care of them in a way that was not going to drag us through the social systems. And I was determined that I didn't want them to be scarred by, realizing that we were poor. So I never told them that we were on welfare and food stamps for 4 years. They didn't know until they were adults and finished college. But we did that because I needed to go to nursing school. My mother was a rehab counselor. She tested me and found out I had a tremendous love for people. So she said, why don't you go into nursing? You'll be able to work night shift. You can be there for the kids in the daytime. You'll make decent money. I wasn't in favor of it because I didn't really like touching people. And I didn't like bodily fluids either. But from a logical perspective, it made a lot of sense. So I went into nursing school, and our life changed at that point. I had a social worker who worked with me, and I went and I told her, if you give me 4 years, I'll never be back on this again. And in 3.5 years, I got my last check. And I was fortunate enough that one of my instructors hired me into a maternal child nursing position. The 6 months before I graduated, I was a nurse's aide. When I graduated, got my boards, rolled right into the RN. And what it did was my children saw their mother push through. When I finished nursing school, we went and celebrated. Let me tell you where we went. We went to Sizzler's Steakhouse, and we had steak and lobster. And boy, were they happy. Because, salad bar and that garlic bread, that gets you going. And they remember that. And they tell me now, when they get older and they start telling you stuff they were thinking and telling you stuff they were doing, I'm finding out all kinds of interesting stuff now. But one of the things they said was, Mom, we watched you not give up. We watched you persevere. And that instilled something in us, even though we're just now realizing that you were trying to raise us and you were a child yourself. You still showed us things through your actions that helped us to build a good foundation for ourselves and for our kids. That's the first part. The second part is I've also had the opportunity to experience health care from the inside. When I was 44, I was diagnosed with hypertrophic obstructive cardiomyopathy. And I had my third heart surgery this past June. And seeing health care from that side, after having been a hospital CNO, a COO, and hospital CEO, it gives you a little bit of a different perspective. Now, here's my question for you. Ratio-wise, physician to nurses, how many do you think there are in the United States? Physicians and nurses. 1 to 2, 1 to 3. 1 to 5? Okay, and which one is the 1 and which one is the 5? You must have been looking at those stats. That's exactly right. There's 5 nurses to every 1 physician. So when you think about that, who really is running healthcare? Who's stabilizing it? Talk to me. Nurses are. My next question for you, and I ask this of everybody, if we were to give, and nothing against physicians, I love them, okay, love them, but we need to deal with some facts here. If we were to give our physician partners the day off, what in healthcare would change? Anything we wouldn't be able to do? One thing. One thing we wouldn't be able to do. Surgeries. Yeah. We wouldn't be able to do surgery. However, if we gave all the nurses the day off, what would happen? Okay. The reason why I preface my comments is because somehow or other it doesn't feel like we really realize that. It doesn't feel when we go out into the hospitals that all of our colleagues actually understand the power that nurses have and the influence that we have in healthcare. And somehow we have to help us and our colleagues embrace that. It's all of our responsibility to do that, and we have to help embrace that. When I went to, well, let me say this. This is my disclosure. I have no conflict of interest. There's no money involved. No big deal. I'm not doing anything illegal. Okay. In this case, what I want to talk to you about, and I'm a storyteller, so be prepared. You'll probably get a lot of stories, is, looking at Dr. O'Rourke's model, these focus areas are so important. She covered quite a few of them. So I'm not going to belabor them, but I'm going to touch on them with respect to nurse executive leaders. Recognizing that we have leaders in all different positions. As a nurse exec, I found out about the difference between authority and influence, and it was very impactful for me. Because I went to work I functioned in a chief nurse position, hospital, market, system. When I got to the system level, I sat down with the directors and we started having conversations. And then I went and I spent a lot of time on the unit, and what I observed on the unit was very different than what I heard in the conversation. The leaders were not the ones deciding how things went. The influencers were. And the influencers were not always the people with the authority and the title. I named them aunties because there were certain people who had been there in those units for a long time, and they were really the ones that were running things. If there was something that the official leader or the one with authority wanted to get accomplished, it didn't happen unless the auntie approved that. And if the auntie didn't approve it, it wasn't going on. So I started hanging with the aunties. Not negating the authority leader title person, but recognizing where the movement was going to happen and who I really needed to work with. A lot of what we're going to talk about is outlined in these key focused areas. The first one is, if we don't know what role we play, how are we going to play it? If it's not defined properly. When you look at nursing leadership in healthcare, there's a lot of things that we need to start to really work on. Excuse the sniffing. It's cold and my nose is running. Collaboration is huge. With each other and with other disciplines. Excuse me. I have some maintenance I have to do here. Just a little dab. Thank you, my dear. Our patients are part of our collaborators as well. And too often we leave them and their families out. But one of our major responsibilities is to make sure that collaboration occurs. My observation is that we have some opportunity there within our profession. You agree with that or no? We have, in many ways, sliced and diced our profession into such small pieces that we're really not able to get movement the way we need to get movement. There's no reason why 5 million professionals somehow have lost their say over their profession. Is that right or wrong? How do you think that happened? Talk back to me, not rhetorical. How did that happen? Internal disputes. How else did that happen?
And having things taken away slowly and not realizing that they were being taken away slowly, kind of like a proverbial frog being boiled on.
That slow cooker. Uh-huh. How else did that happen?
The ability to not see it coming.
Yeah.
Because you don't know what you don't know.
You don't know what you don't know, and you don't know the framework or the scaffolding of your profession. You know, when I ask people, how many people are familiar with their code of ethics? Very few hands go up. Scope of practice. But yet that's really the foundation of what we're doing. It should be embedded in everything that we do, but most people don't know it. I'm one of those, I'm kind of type A. I'm not kind of type A, I'm like major type A. And when I decided to go into nursing, I wanted to learn, what is this? And how am I supposed to do it? So I studied. I studied the scope of practice. I studied the code of ethics as it was at that time and have updated myself since then because it's been updated. I looked at everything I could look at with respect to nursing so that I would know how to do this right. And I want to tell you something that was discouraging, but it didn't change my motivation. I got in trouble a lot. I got in trouble a lot on my jobs. And the reason why I got in trouble a lot was because I stood by that standard. And the hospital wasn't. And I'm not one of those people to yell and scream and raise and beat the drum. I'm one of those people to just sit there and look at you and just not do it. You know, so in many cases, when I was ordered or directed to do something, whether it was by a physician or by an administrator, if I didn't agree with it or it wasn't aligned with my vision, my values, what I believed I was supposed to be doing, I just didn't do it. You know? And they asked me, why won't you do this? And I'd give them a logical reason why I'm not going to do it. One example of that was there was a lady, I'll tell you, it was Nurse Sexton. I'm not going to say her first name. But in this hospital, they still wore the staunch white and the white hose and the white shoes and the cap. My problem was when it came to infection control, the caps were not laundered properly. And so I would see people's caps kind of dipping in people's wounds, and they were dirty and stuff. And so she was telling me that I needed to wear a nursing cap. And I said, no. And she said, well, that's the uniform. I said, I understand, but it's not a hygienic thing to do. And she said, well, this is the policy, and you're going to have to do it. So I went, and I got a little cap made, because I wasn't capped in nursing school. I was pinned, so I didn't have a cap. I went and got a cap made. Guess it was that big. And to add to it, I had an afro. So it was right there in the back of my head, but you couldn't see it because it was all lost in the forest of my afro. So I came to work the next day, and Miss Long, where's your cap? I did a spin. Oh, and she goes, oh no, that is not a standard approved cap. Where's the one that you got when you graduated? I said, I didn't get one when I graduated. I got pinned. And then she said, why are you being so difficult about this? I said, because of two reasons. One is because these things are not laundered properly and they're an infection control risk. And I walked her around the hospital and let her see these dirty, nasty caps that these nurses were wearing. Is that okay? The other reason was because I told her, if you look at the nurses who have worn those caps for years, they have a bald spot in the back of their head. And I'm not having that. Nurse Sexton and I came to a compromise because I was a CVICU nurse. And she said, as long as you wear scrubs, you don't have to wear the hat. And then she loosened up this hat requirement, and eventually the hat requirement went away. Now, did I get in trouble for that? Yeah. Was it worth it for me? Yes. Because it made the change that needed to be made for the sake of the patient. Because who wants an old, nasty, dirty cap dipping in their wound? You know, come on now. It's a way to exhibit that leadership early on. She and I collaborated. It was a little tense at times, but we managed to get that done. Patient care quality was a huge piece of that. And then advocacy. It wasn't personal other than the bald spot in the back of the head. What it was that I felt like we needed to really look at the bigger picture here. Because she was stuck on tradition. And tradition is good foundationally. But if you get to the point where you find that sticking with that tradition is now putting patients at risk, you got to flip your script a little bit. Speaking of one of my favorite people, Dr. O'Rourke's model on professional role really looks at role clarity. It looks at professional role identity, the interprofessional collaboration, ethical practice, advocacy, and continuous professional development. And if you look at all of those things, as I sat last night, Dr. O'Rourke, and I looked at your graphic. And I broke it down in pieces because it's a very complex graphic. But it also tells a story about evolution and flow. And it was fascinating to me. And I started to include it in here, but I was like, no, because I need to study this a little bit more and make sure that I fully understand this, because it's complex, but it's a beautiful model that outlines the interconnectivity between all of these things and the world of nursing and what it is and what it can be. So when you're looking at role clarity, it's really very simple, and that is we need to know who we are, what we are, and why we are. Now, I will tell you, just based on the model and reality, our roles, it's a dynamic movement thing. Because depending on where you are, who you're working with, what the need is that we have assessed, that role may ebb and flow a little bit. But it doesn't change the fact that we need to know what it is. And we need to live in it. We need to embrace it. As I tell my kids, we need to say it with our whole chest. Do you know what that means? You got to feel it to the core of your soul when you're talking about, this is who I am, this is what I do. We have to make sure the decision-making authority is understood within that. We have to make sure that the contribution to patient care is clarified appropriately. And we have to be sure that the key profession within healthcare is established by the nursing professionals. Now, I will tell you that I think we have been remiss, and I believe that Dr. Stanley and Dr. O'Rourke are beginning to remedy this, or have remedied this to a certain extent, and that is we have not empowered and informed incoming nurses of what the nursing profession really is. The purpose has not been imprinted. In talking with incoming nurses, they don't understand. They don't understand what this role really is, what the profession really is. They understand that they make good money. They understand that they can buy their Maserati. But they don't understand the advocacy piece. They don't understand their responsibility. You know, I have another role that I've served for 27 years. I've been a legal nurse consultant expert witness since 1999. And I had an attorney one time accuse me of being a hater. And I said, really? He said, yeah. Because I was testifying that a nurse and a hospital breached their duty. And he told me that I was a hater. And I said, no, that's not why I'm doing this. I'm doing this because as a professional nurse, I have a responsibility to assist my other professional nurses in living the full responsibility of their licensure and role. And if they're not going to own what they did and make the correction, then they're breaching their responsibility of advocacy and protection of the patients. And if the hospitals don't own when they did something wrong, they're going to continue to do something wrong. My responsibility, I feel, is to share with them, here is where the error took place. Do something about it so it doesn't happen again. Don't keep covering this up. Fix it. That particular case was a gentleman, it was a fall. And a woman had just come out of surgery, and she was 340 some odd pounds. And he said that she rolled over the rail onto the floor. Spare me. There is no way that if that rail was up, that poor lady was going to end up on the floor. What ended up happening to her was her stitches tore, her hip fractured, and she died when they went into surgery to try to fix it. And he sat there in court and said that she rolled over the rail. The attorney I was working for, they know me very well because I've been working for this particular, I work for 8 law firms. This particular one I've done a lot of cases for. All she did was take her hand and go like this. That's all she did, because she knew I was coming out of the chair, you know. So I just waited until it was my turn, and then I just told them logistics of the railing and this. And this particular attorney is a visual attorney, and so am I. So we have slides. And she shows what things look like, and it makes a difference. But I said all that to just kind of reinforce that particular nurse had breached. He didn't understand what his role was. He didn't understand what his responsibilities were. And I had to figure out a way to help him see that. And it may not have been pleasant for him, but it had to happen. From a nurse executive perspective, the nurse executive's responsibility is very broad. But the biggest responsibility is to the patient and to those who care for the patient. And we can't be so far away from the point of service that we lose touch on that. The directors of nursing and deans of nursing programs' responsibility is to help people know that the patient is the primary person. And the things have to be focused on what works best for them. We say we want to do what's best for the patient, but do we always? Do we advocate for that? And what I'm saying is not accusatory. I'd rather it be thought-provoking. Just think about whether we do or not. And if we do, wonderful. And if we don't, we need to start. There's a strategic leadership piece that the nurse exec has to make sure is clear to everybody else, as well as what is the vision of the organization? What are they trying to do? The quality and safety piece is huge. How many people are hospital-based? Okay. How many times do you see your chief nurse out on the units? Okay, we got one. Your chief nurse out on the units, more so than just, hey, how you doing? It's good to see ya. Does your chief nurse work shifts or side by side with people to see what's really going on? But this is the responsibility that our chief nurses have. They need to know what's happening at the point where the service takes place. I know the job is big. I've done it. But we have to know what's happening. And unfortunately, many chief nurses base their decisions on what the manager told the director, who told the executive director, who told them. How clear do you think that story really is? You know, if nobody deliberately tries to change anything, how clear is the story? But the decisions are being made based on that. So there needs to be some work there. Workplace leadership or workforce leadership and professional practice. Nurse executives are responsible for that, as well as financial stewardship. We're responsible for interprofessional collaboration. We talked about that a little bit. The policy, advocacy, and governance. Shared governance, is that really a thing? Are we doing it? Pet peeve number 1. Why do we have to get ready for Joint Commission? Okay, let's go back. The standards in Joint Commission were put in place because at some point someone was harmed. Yes? Okay. And policies and procedures are put in place in order to remedy and be proactive in making sure that things are done in a standardized fashion and that no one is harmed. Yes? Okay. So Joint Commission is put in place to come in and validate our adherence to the things we put in place that we committed to the patient we're going to have in place so we don't harm them, yes? So why do we have to get ready for it?
Because we're not doing what we said we were going to do.
And what does that take us back to? What did we just breach? Pretty much all of it. Yeah. It made me crazy. When I was a hospital CEO, I sat down with the team and I just told them, we will never get ready for Joint Commission. And I don't ever want to hear those words in this building. We will be ready because we're going to do things correctly all the time. It's going to be standard of practice, and we're going to make sure that all of our colleagues do it this way. It's in policy. Why is it not in practice? Because of that, when Joint Commission was coming, it didn't matter. We were always ready for them. And they found that their stress level was significantly less, as was mine, because I was not going to deal with us straying away from our obligation to keep our patients safe. It's not about the rule. It's about why the rule was implemented to begin with. Magnet. You know, I told you I was a little controversial, so don't get mad at me. If your culture is aligned with magnet requirements, why do you have to put all this stuff in place and get a coordinator? Pause for effect.
Only for document preparation.
Yeah.
The administrative work is deep.
They require that you document what you've done and why. If you work on getting that culture embedded as the culture that you're functioning within, it's not a heavy lift to get that designation and maintain it, because it's part of what you do. It's part of who you are. It's part of the organization's identity. It's the chief nurse's responsibility to get that permeated. And then the innovation and transformation. As a chief nurse, one of the things that I enjoyed doing was doing new and different things. I am not a within-the-box person. I'm sure you figured that out. I don't have a box. You know, I'm one of those people who go, hey, I was reading such and such, let's try this. What do we need to do? How much money do you need? It was easier to do that as the CEO because then I could just designate the funds the way I wanted to. But it's okay to try different things. We don't have to always do things the way we've always done them. But we have to be willing to step out there and make sure that we empower people to try different things. So the professional role identity, who are we really? We want to try to make sure that we foster a sense of belonging and accountability. And as Dr. O'Rourke said, the accountability rests within us. But we also have a responsibility to assist our colleagues in maintaining the expectation of the profession. Now, everybody doesn't embrace that, and I respect that. But I've chosen to do that because I feel that when I have RN behind my name, it's not just me that I'm representing. It's the other 5 million nurses in the nation. It's the other 500,000 nurses in the state of California. And I owe it to my colleagues, my profession, to represent them in the most positive light. That's what I'm supposed to do. And so when I see one of the colleagues that is not doing that, I just ask them, do you really want people to view us that way? Or you that way? And see, that was embedded because my parents felt very strongly about our family name. And they instilled in us that we need to represent our family name in a most positive light because our father and his father and his father worked really hard and went through a whole lot of stuff for that name to survive. And so that, for me, got translated onto the nursing profession, too. And so I was watching the other day, I was watching a video, and I'll apologize ahead of time for those who are supporters of this person, but this is just an incident that I saw. Our FBI director was having a good old time with some alcohol, and he was just partying it up. And there was a discussion online about that. And people were saying, well, does he not get a chance to party and blah, blah, blah. And, I just said, well, that's not it. The issue here is that he holds a certain position. And it's a law enforcing position. And he has to be mindful of the optics of what he's doing. He can party all he wants to, but just be mindful of the optics because he is representing the Federal Bureau of Investigations and the administration that's running this country at this point. He has an obligation to represent that group more positively. Or, the partying and the falling out and the drinking and the red eyes and all that stuff is going to be reflected on everybody. So all I'm saying is understanding the impact of all of that is vitally important, and we have to embed in our soul that we're going to represent better. We're going to make sure that we have our professional role identity defined, that we understand how it works within the environment that we're in, that we understand that it's dynamic, it's going to ebb, and it's going to flow. But we have to know what that is. Your nurse exec has a hybrid role because they're clinicians, but they're also strategists, they're executives, they have to emulate the professional values. And I have to tell you, in the cases that I've worked, and I'll say this, I can say this very honestly, the hospitals that have done the most harm are the ones where the nurse exec did not stand up for the nurses. Those are the ones that you see the biggest harm. There's one case that I'm working, 8 different patients, same hospital. 8 different patients had the same thing happen. It was like clockwork. In my report, I can almost cut and paste, just change names and lab values. It's that consistent. And in general, what happened was the person had a stroke, they were admitted to the hospital, they did not get the proper care, they developed hospital-acquired pressure injuries, and one of the major things is they ended up culturing Klebsiella and E. coli in the sputum. Now you know where Klebsiella and E. coli reside. It has to be physically moved, manually moved to the respiratory system. And these people, of course, die of sepsis. 8 of them in a 2-year period. Who's watching the hen house here? I sat down and talked with some of the nurses, and what they said was that their chief nurse wasn't hearing them, that they were telling them that they were concerned about it. They weren't hearing them. I looked at the staffing over a period of those years, and there was never enough people. There weren't enough supplies. Who's really responsible for that? The nurse executives. That's her thing. That's his thing. I've also seen where hospitals are run phenomenally well, where the nurse executives connected, that they're supportive, that they advocate, and these types of things I haven't seen. So it's much bigger than, I need to understand what my role is. This thing impacts everybody that crosses our way. Everybody. And that's so important. So when you're talking about interprofessional collaboration, we also need to look at knowledge transfer, communication, and collaboration. My son was a football player, and I was the football mom. I used to have to shop at Costco with a hand truck because I had these big, after the game, these big old football players, probably about half the team, would show up at Mama Kim's house, and I was frying burgers. One of the things I learned from that experience, and I'm a football fan now, go Niners, is that each person plays a different role on that team, and they have to master that role. They have to understand the role of others, but they have to master their role because everything kind of works in collaboration with everything else. The teams that win are the ones that really optimize that collaboration. And the ones that are not quite as good are the ones that you have the hot shots that want to focus on themselves, and they're always talking about throw me the ball and this, that, and the other thing. And so while I was feeding these big fellas burgers, I would talk to them about that collaboration, about how they had to optimize the expertise of their peer or of the other people, because all of those pieces come together for the best outcome. That interprofessional collaboration it's essential to optimal practice. We learn from it. Our practice is enhanced by it. But how often do we find people that don't want to hear what somebody else has to say? Well, you're not of this or you're not of that. Or they won't bring other people into the committee that are impacted by the decision. How many times have we seen where we make a decision about a process, but all the people who were impacted by that process aren't in the room? And then we have to figure out, it happens to us a lot, I'll be honest with you. It happens to nursing a lot. We have people sitting around the table and they're talking about what nursing is going to do, and nursing is not at the table. And so the subtle nuances aren't really fully understood. I had a situation where I went into a hospital and they had been trying for months to figure out what was wrong with the narcotic count, because it was right around the time that the Pyxis were rolling out, and this one particular narcotic kept coming up short. And so I went and I sat through their first meeting, and they were talking. Hour and a half later, meeting ends. Okay, we're going to meet again next week. They came back together, talk, meeting 2 for me. About the third meeting, I said, give me a second. And I went and called pharmacy. And I said, tell me how this Pyxis works. And they told me. And then I went and I got 2 of the nursing staff, and I sent the management team up to cover the nursing staff. And then I said, when you get ready to take this medication out, what happens? Well, this drawer opens up, but this drawer opens up too. Okay, and then what do you do? Well, I close that drawer and then I just get what I'm trying to get. Now, they had been meeting for months before I got there. And it was almost a month after I got there that they were meeting too. But not one time did they bring the staff nurse in to find out what was going on, and not one time did they have the pharmacist in the room. They bring a perspective that we don't have. We bring a perspective that the CFO doesn't have, that the CEO doesn't have, unless they're a nurse. But yet we don't want to open up and say, come on in here, bring that perspective. Let me hear what you have to say. There's opportunities for enhancement when we do that. There's opportunities for stronger teamwork and for appreciation of what each does. We miss opportunities to enhance what we do, and we miss opportunities to enhance ourselves and our own knowledge. And then let's talk about ethical practice. Are the code of ethics still taught in school? Yes? We're teaching the code of ethics? How deep do you go?
How deep?
Uh-huh.
The books from very first class. And it is embedded in clinical, it is embedded in simulation, it is embedded in debriefing.
That's the word I was looking for, Dr. Pam. Embedded. That's the word I was looking for. I wonder if all of the schools are doing that. As a CNO, during the orientation, I sat down and I went through the code of ethics with the new nurses. And most of them hadn't even heard of them. They didn't understand the connection between these principles and their nursing practice. And see, all of these things should be embedded because this should be what we do and how we do it. But we kept it on the surface. And I'm so glad to hear that it's embedded. And I'm really excited to see the group that graduates from St. Mary's program. I want to see how they work and how they think, and do they really understand? I'm sure they will, because the core of what needs to be done is being done. I'm going to touch on advocacy a little bit, but I'll talk a little bit more about it on Friday. There's an obligation that the nurse exec and everybody else has to be the powerful voice for the patient, the nurses, the healthcare system, and make sure that the decisions are being made at the highest level, including the embedded ethics, including integrity, including workforce sustainability, care delivery, equitable and high quality care. That's what we're supposed to do. Now, last time I checked, in California, there were 35 bills that were under consideration that would impact nursing. Did you know that? There was 35. That was the last count that I had. These decisions are being made and we're not there. And then we get the downhill and we have to change things. And I will say this. I think it's wonderful, as innovative as we are, but sometimes that innovation has worked against us. Why? Because we lose resources, we lose expertise with budget cuts and things like that. And then they say, nurses will make it work. They always do. And we are so good at jerry-rigging stuff. We're good at it. We know how to make things happen. You know? But what does that do to us as far as our voice being able to say, this is what we need and this is what you're going to get for us? Because we make it happen, which is not a bad thing. It's a good thing that we make it happen. But then when we make it happen, the bean counters are saying, well, don't worry about it. They'll make it happen. So there's a good and a bad to it. You don't want to lose that. You just want to realize when to use it and when not to use it. And then the other piece is lifelong learning. It's not the hospital's responsibility to make sure that we stay up on what's going on. It's our own. We're the ones that's licensed. I got another story for you. So as system chief nurse, I was at a public hospital, and it was 5 different hospitals and 6 community clinics. And they were heavily unionized. There were 32 unions in this facility. And I got elected, lucky me, to be the administrative representative to work with the unions. So this one particular time, they came in and there was a lady who had been an officer with the union who was just wreaking terror, that incivility, Robin, that word. She was like the epitome of incivility. They were just letting her just wreak havoc. Oh, she had new grads in the closet crying. She beat up the security guard. I mean, this woman was out of control, and they kept saying, well, you know, she had a heart attack and her son got shot. I don't care. And when I came on, I was responsible to evaluate whether she had met the requirements of her performance improvement plan. Now, they had put her on a PIP because she had been a night shift charge nurse. They put her on day shift to keep an eye on her, but they let her keep her night differential. So this woman is sitting at the table, and I have a stack of charts because I'm telling the union that I'm going to retest all the nurses, and if they don't pass this test, that I'm firing them. Now, this is the union, and they're looking at me like I'm crazy. I said, no, this is what's going to happen because the nurse's competence is of great concern to me. This stack of charts were patients that a nurse's error had killed. And I just had the first 12, the 12 worst ones. And so I sat with the union and I put this one down, and this one the nurse is killed by doing blah, 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 and this one the nurse is killed by doing this. Now, what I didn't tell you was that I was on prednisone at the time. I was on 60 milligrams of prednisone. So I was just a little bit hyped up, just a little. And so I'm telling them this story. Well, the girl who was on the performance improvement plan chimes in, and she says, well, this hospital has not given us continuing education programs in 2 years. Well, guess what? The prednisone kicked in. And I stood up. Now, those who know me know that I'm pretty calm spirit. I'm really easygoing. I very seldom yell. When I yell, it's got to be bad. I'm just, you know. I stood up, and the prednisone was at height. I'm going like this. I go, you are responsible to make sure that you stay competent. It is not the hospital's responsibility to make sure that you keep your education. The license is yours, not ours. By the time I got through with those people, HR and a couple of my directors, what they said to me was, Kim, let's go to your office and have a caucus. Okay. So I went in the office, and one of my directors' name was Dana. She was my director for nursing finance. She said, did you say you were on prednisone? I said, yeah, why? How much? I said, 60. And she goes, oh, okay. But you know what the prednisone did? When I went back in there, they agreed that we were going to retest those nurses. And we set up a follow-up board. It was Mosby's at the time. Everybody had to take that test. And then the specialties had to take another test. And if they failed with less than 90%, then they got 3 study days that we paid. And we told them you can do study groups and everything else. When they came back, they had to pass at 95. Fired 8 nurses. Now, what I didn't tell you was the mouth, the lady in the room, one of those cases we were investigating because she had overdosed a patient in insulin because she did not pay attention to the family telling her that there was a blood sugar that she didn't consider. She was treating the old blood sugar. She overdosed the patient. The patient had an anoxic brain event and died in the ICU. She did not know that we were investigating that. Long story short, they have been trying to fire this woman for 20 years, and I fired her. Elvis left the building. because my responsibility was to make sure that patients were safe. And the patients weren't safe around this woman. The new graduate nurses weren't safe around this woman. None of them were safe around this woman. The lifelong learning piece is our responsibility, nobody else's. The continuing professional development is our responsibility, no one else's. And we should do that gladly. You know, there's no excuse now because we have Audible. If you can't sit and read the book, you can buy it, and you can listen to it while you're driving somewhere. I see Robin standing over there. So I'm going to wrap this up, and I'm going to say that advocacy is important. We have to make sure that we advocate as a collective. I'll go into more detail about that on Friday, but I want to say this. Just because it's not our specialty, it doesn't mean it's not our responsibility. We're a nursing profession. We advocate for nurses. So our voices will only be heard at the volume that they're supposed to be heard if we advocate as a group. There's 500,000 in California. There are 5 million in the United States. There's no reason why our voices aren't being heard. Thank you so much.